We're going to be recording this session. Okay, so there you heard the notification. Welcome everyone. We're so happy to have you here today. Whether you are new to working with or learning about the agricultural worker population, or you are very familiar with this population, we welcome you and we hope you will take away some new knowledge today. So we're going to be covering 4 learning objectives. Our hope is that by the end of this session, you will have a foundational understanding of agricultural worker health and some of the unique factors that impact this special population and their access to healthcare. So by the end of this session, you'll have an understanding of how the Migrant Health Program functions and is funded. You'll be able to identify ag worker demographics and discuss how these demographics and the culture of the population impact healthcare access. And you'll be able to identify some of the unique challenges and barriers faced by the ag worker population. And last, you'll be able to describe some services provided by the Migrant Health Program to the ag worker population. So for those of you who may not be familiar with NCFH, we are a nonprofit organization located outside of Austin in Buda, Texas. Our mission is to improve the health of farm worker families, and we do that by providing programs, trainings, and technical assistance and resources. We just celebrated our 45th anniversary in 2020, and we're very proud to be serving the 177 community and migrant health centers in our network who provide primary care services to agricultural worker families. One of the ways NCFH works to improve the health of ag worker families is through our Ag Worker Access campaign. The Ag Worker Access campaign was launched in 2015 as a joint effort by NCFH and the National Association of Community Health Centers. So we, along with the health center staff and other ag worker advocates, knew that more could be done to increase access to care and quality healthcare for America's agricultural workers and their families. So the result was the Ag Worker Access 2020 campaign, which has since been renamed the Ag Worker Access campaign. Since the campaign's launch, we saw steady increases in the number of ag workers served in community and migrant health centers through 2019, when health centers reported more than 1 million served for the first time in the history of the Migrant Health Program. There was a slight decrease in 2020, likely due to pandemic, but we are continuing to work toward reaching our goal of at least 2 million ag worker families served. We need your help and we hope you'll join this initiative. Please visit our webpage to learn more about the campaign. So to get started, in order to understand the Migrant Health Program and when and why it began, it's important to take a look at the history that led up to the program. The US has imported agricultural workers for a very long time. From our nation's creation, agriculture and the small family farmer were considered essential components of democracy. Starting in the 1850s, there were major advances in crop production, and crop production was growing larger and larger. Additionally, as crop production grew, there were wars throughout the world, causing labor shortages to work in the fields. The demand for immigrant labor continued into 1917 when the US entered World War I. And in response, Congress passed the Immigration and Nationality Act, which established a legal basis for the importation of 70,000 workers from Mexico. This was the first guest worker program in the US. Then again, when the US entered World War II, commercial farmers faced a high demand for their products without sufficient labor. So the US called on Mexico again to fill this labor void through the establishment of the Bracero Act, which was the largest guest worker program to date. Although the Bracero Act was devised to meet the World War II shortages, the program ended up continuing until 1964, ultimately employing roughly 5 million Mexican laborers. In 1952, the H-2 program was established. This program is similar to the Bracero Act, but requires certification of labor shortage to legally import workers. This program is still in existence today as the H-2A program. By 1962, many ag workers in the fields were experiencing harsh conditions, low pay, and little access to care. President John F. Kennedy signed the Migrant Health Act, also known as the Public Health Act, Section 329, which authorized funds to create a small number of migrant health centers to provide preventative and primary healthcare services to the ag worker population. Initially, the Migrant Health Center served only agricultural workers and therefore operated only during the agricultural season. This created a community sentiment of preferential treatment to agricultural workers within the communities where these migrant health centers were located. Community members expressed dissatisfaction and demanded access to these healthcare centers. In response, the federal government made money available to health centers that already received migrant dollars to jointly serve the community under Section 330 of the Public Health Services Act. This meant that health centers receiving federal assistance under Sections 329 and 330 were under obligation to provide services to both migratory agricultural workers and the community as a whole. Although some health centers have done an excellent job in maintaining the focus of serving both populations, others have been overwhelmed and challenged to maintain the same level of focus in reaching the agricultural worker community. This problem is further aggravated by the limited resources available to provide outreach, translation, transportation, and other enabling services needed to serve this hard to reach population. So in 1996, Congress approved the Health Center Consolidation Act, which authorized the consolidation of Migrant 329, Community 330, and Homeless 340 sections of the Public Health Act under the umbrella of 330 programs. Under this consolidation, migrant health money was integrated into community health funding, and it expanded its reach to include aged and disabled agricultural workers. Section 330 of the Public Health Service Act defines health center program as a funding opportunity for organizations to provide healthcare services to underserved populations. So what is the definition of agriculture? The HRSA definition is farming in all of its branches, including crop production, animal production, aquaculture, and support activities. Agriculture involves everything from prepping the soil, seeding, planting, growing, picking, packing, to transporting. Considering the various types of work that the definition of agriculture includes, there are several classifications of agricultural workers. These are the definitions of agricultural workers as defined by Section 330G of the Public Health Service Act. So we have migratory, seasonal, and aged and disabled agricultural workers. By definition, migratory workers, their principal employment is agriculture, and they have been employed within the last 24 months or 2 years and have established a temporary home for the purpose of working in agriculture. Seasonal agricultural workers have a principal employment in agriculture on a seasonal basis, and they have been employed within the last 24 months or 2 years. They are not a migratory worker because they have not established a temporary home in order to work in agriculture. And our aged and disabled agricultural workers are former migratory workers who are unable to work in agriculture due to age or disability. An important thing to note about these classifications of agricultural workers is that agricultural workers and their family members receive the same classification. So for example, if a seasonal agricultural worker comes into a health center, the seasonal agricultural worker's spouse and family members will also receive the same classification as a seasonal agricultural worker. So a great way to understand the ag worker population is to take a look at the most recent demographic data on the population. Data on agricultural workers comes from the National Agricultural Workers Survey, or NAWS data, which gathers data on demographics, employment, and health characteristics. This is a survey that's conducted annually and is a random field survey. These results are not published every year, and the data we're sharing today is from the 2017-2018 data. And in the chat, you'll receive a link to our NCFH fact sheet that was developed to summarize some of the key statistics from the survey. So looking at some of the general demographics of the ag worker population, starting with age, the average ag worker is 41 years old, with 68% of the population between 25 and 54 years old. 1/3 of ag workers are younger than 35. The gender breakdown is roughly 69% male, 31% female. For ethnicity and race, 77% of ag workers identified as Hispanic, and among US-born workers, 30% identify as Hispanic. More than half of ag workers are married, about 57%, and half of ag workers are parents. Looking at income, 71% of ag workers earn below the poverty line, which is an annual income of less than $30,000. Looking at the educational attainment in this population, the average educational attainment is 9th grade. And breaking it down a little further, 35% have completed 6th grade or lower, 18% completed grades 7, 8, or 9, 31% completed grades 10, 11, or 12, and roughly 12% completed some education beyond high school. Looking at language, Spanish and English are the primary languages in this population. 65% of ag workers prefer Spanish as their speaking language, and 27% prefer English. Among workers born in Mexico or Central America, nearly all reported that Spanish was their primary language. Although Spanish and English are the primary languages in this population, we do also have to consider other languages, such as Haitian Creole and indigenous languages that are also present within this population. Looking at healthcare utilization, the data shows that 71% of ag workers used healthcare services in the US in the last 2 years. 26% paid for services out of pocket, 16% paid using personal or family insurance plans, and 24% used Medicaid or Medicare, and roughly 11% were not charged for their visit. When it comes to employment, agricultural work is not steady. It is dependent on season, weather, and market demands. Year-round work is not always possible due to the nature of agriculture, because of the seasons, crop production, and weather, of course. Agricultural workers are typically employed by the growers or packing firms directly. About 89% of the population are employed this way, and a small percentage, roughly 11%, are employed by labor contractors. Workers may not be employed in agriculture when they seek care at a health center, but still can be identified as agricultural workers if they've been employed in agriculture anytime in the last 24 months or 2 years. So looking at some of the working hours, workers' hours accommodate the crops, not vice versa, and therefore can be paid by different methods. 42% of ag workers work more than 8 hours a day. On average, workers work 35 weeks of the year in agriculture, 6 weeks doing non-agriculture work, and 9 weeks unemployed in the US, and an average of about 2 weeks per year outside of the US. Looking at the migration patterns, 13% of agricultural workers are migratory, 87% of agricultural workers are seasonal. Of those migratory agricultural workers, 47% were domestic, and 42% were international, and 11% had been in the US for less than a year. Breaking down the different types of work, 41% work with fruits and nuts, 20% work in vegetables, 22% work in horticulture, and the migratory workers were less likely than seasonal workers to hold a job in horticulture. For housing, 26% reported living in a crowded dwelling where more than one worker shared the same room, and 11% live on the farm of their current employer. So we're going to look a little bit more into the working and housing conditions for this population. Looking at working conditions first, as I mentioned, the availability of work depends on the season and weather and market demands. Hours can be extended from the early morning into the evening hours or done every day versus 5 days a week. Income can fluctuate. Income can be paid by the hour, paid by the piece picked, or some are salaried. And about 86% of ag worker households had not received a benefit of a needs-based program in the past 2 years. Adequate, affordable, and safe housing has been and continues to be a constant struggle for migratory and seasonal agriculture workers. A small 14% of ag workers may have housing provided by their employer. This is often the case for migratory workers, given that they travel for work, and is traditionally met by growers through the establishment of labor camps. Employers recognize that the lack of housing is a serious problem, but they face several disincentives to providing housing for migratory workers. Given construction and maintenance of these labor camps is expensive, especially if the housing will only be occupied during a short harvest season, housing is often substandard. However, most ag workers do not have housing provided by their employers and often need to find housing on their own. Nationally, 50% of workers reported renting property for housing. However, most communities may not have enough rental units available, or they may be unavailable to ag workers because they cannot provide deposits, qualify in credit checks, or make long-term rental commitments. Therefore, ag workers struggle to find places to live, especially in rural areas where housing is already limited. Some end up sharing rental properties with others who work on the same farm to make it more affordable. However, much of the housing available for them is deficient, crowded and unsanitary, so this adds to their health risks. Crowded housing, as we'll talk a little bit more later in the session, also makes it difficult to practice those social distancing recommendations that we've become so familiar with over the pandemic. Some ag workers have their own private housing. This is about 35% of the population. This is often the case for seasonal workers. Private housing is not subject to federal regulation. Therefore, what is available to ag workers tends to be substandard and many times expensive. We often see workers living together under these conditions as well, especially with many family members and relatives. Again, this also plays into the difficulty to practice quarantining and safe social distancing recommendations. In the absence of housing, ag workers may be forced to sleep in tents, cars, ditches, or open fields. So as mentioned in the previous slide, much of the housing available to ag workers is deficient, crowded, and unsanitary, and this adds to their health risks. So some of the common illnesses related to housing that we often see include UTI and intestinal parasites, skin conditions, respiratory conditions, and infectious diseases. So just to pause here for a quick reflection in the chat, if you all don't mind sharing. Outside of some of the challenges that we have just discussed related to ag worker housing, what are some of the challenges that your health center has faced or identified amidst the COVID-19 pandemic that have impacted this population? And feel free to use the chat or the Q&A feature to share some responses. Okay, vaccine hesitancy. Yes, that's a big one right now. Misinformation. That's huge, I think, for all populations, but definitely for the ag worker population. Misinformation is difficult, especially with language barriers and where information and resources are coming from. Access to personal protective equipment. Continued need to work while sick. In wildfires, yes, that sounds very high risk. And we'll talk a little bit more later in the session about how that continued need to work, the way the work is set up, adds risks for ag workers as well. Unable to do telehealth appointment. That's a big one. Service delivery has definitely been impacted by COVID-19. Right. Great, thank you all for sharing. So to wrap up this section before going on to some of those occupational risks that I was alluding to, there are a few traditional patterns of mobility with this population. There is restricted circuit migration. These ag workers follow crops in one area and are centered around a home base. So they move to work, but they come home frequently. And these are typically our seasonal agricultural workers. They work within 75 miles from home, and typically there's less transporter crossing and more workers are engaged in other industry work during the off season. So when they're not harvesting or working in agriculture in the off season, maybe they're working in construction or in another type of industry. Then there's point-to-point migration. These ag workers move away from home base for extended periods of time. They often go back to the same location multiple years in a row, and sometimes travel as a whole family. And these are our migratory workers. The number has significantly decreased in this population over time, as seen in the data. And roughly right now, there are 13% of ag worker population is migratory. Our third migration pattern is nomadic. These ag workers travel to wherever there is work. They usually do not know when or where they will move to next and are generally foreign-born, young, and single men. I did want to make one note that the NAS data does not include H-2A workers, and our H-2A workers are all migratory workers, and we know that they account for roughly 10 to 15% of the ag workforce nationally. So moving on to some occupational risks. As we can imagine, our agricultural work definitely has some occupational risks. Agriculture is consistently ranked as one of the 3 most dangerous occupations in the nation. In 2019, there were 573 deaths due to work-related injuries. Immigrant workers are often even more vulnerable to things like labor trafficking, where an employer may control the movement of their workers through threats, physical abuse, debt bondage, or other means. Agriculture has the second highest number of reported labor trafficking cases in the US. And there's increased risk for illness and health conditions with COVID-19, especially now that agricultural workers are considered essential workers. So as mentioned in the chat, that needing to work even though they're sick because they're so essential to our food system. Many of the occupational injuries that ag workers face are related to the specific type of work that they do. Some examples are musculoskeletal injuries and disorders such as carpal tunnel syndrome, shoulder impingements, sprains and strains, and low back disorders. Repetitive motions and heavy lifting can cause pain, arthritis, and other health problems. There are various motions that agricultural workers do that can contribute to these ailments, such as stooping, picking, carrying, lifting, using various equipment, packing, and even falling from ladders. Other risks relate to the way that agriculture work is set up in general. So due to being outside all day, weather plays a major role and can contribute to heat stress and dehydration. They are also at risk to insect, rodent, and snake bites being outside all day. The practice of piece rate wages versus hourly wages encourages people to work longer, harder, and faster without taking breaks in order to earn more income. And beyond the expected physical impact, this practice contributes to workers not taking the time to take care of themselves while working. So not going to medical appointments, the lack of management of chronic health conditions, all because they don't want to lose out on the potential income they could be earning. Vehicle accidents are a large problem among agricultural workers as well. Workers are often transported to and from work by crew leaders in unsafe vehicles, which may not have seatbelts or may be overcrowded. In addition, because some agricultural workers migrate, the opportunity for accidents on the road is greater for agricultural workers compared to the general population. As also mentioned in the chat, with COVID-19, the lack of safety precautions, the lack of PPE, the lack of social distancing requirements, lack of hand washing stations, and inability to quarantine are additional occupational risks. So this slide highlights some of the problems associated with field sanitation, pesticide exposure, and environmental risks associated with agricultural work. Agricultural work often requires, as mentioned, stoop labor, climbing, and carrying heavy loads, but additionally working in the soil and with direct contact with plants. This direct contact with plants can put ag workers at risk for exposure to pesticides and chemical fertilizers that are used in cultivating plants. Some plants, such as tobacco and strawberries, release chemicals that are toxic to humans or that can cause severe allergic reactions, such as contact dermatitis. In addition, there are some anecdotal reports of workers resorting to irrigation ditches and runoff ponds when safe water is not available for drinking and washing. Pesticides, chemical fertilizers, and organic waste can contaminate this water and can lead to illnesses including conjunctivitis, intestinal illnesses, cancer, infertility and birth defects, developmental delays, neurological disorders, many things, and many of these can be misdiagnosed given their common symptoms. The EPA estimates roughly 10 to 20,000 poisoned ag workers a year, and exposure to pesticides and chemicals can also put the family members of ag workers at risk, given that there's residue left on their tools, clothes, shoes, and skin that they take home to their family members. Additionally, the unavailability of safe drinking water, lack of nearby toilets, lack of nearby hand washing facilities can all increase risk for illness and adverse health outcomes. So to address some of these occupational environmental risks, there are three main regulations that have been put into place that are specific to ag workers. The first is the Department of Labor put into place Migrant and Seasonal Worker Protection Act of 1983. This establishes the right of ag workers and the guidelines for labor contractors to follow. The second, OSHA put into place the Field Sanitation Standard of 1987. This applies in all states and requires the availability of water and sanitary toilet facilities. OSHA has put regulations into place that require agricultural employers of 11 or more workers to provide drinking water, hand washing facilities, and toilets for their employees. However, farms with 10 or fewer employees are exempt from these requirements. The intention of this exemption was to avoid placing an undue financial burden on small farms. However, as a result, these very basic amenities are not required by law for many ag workers, regardless of the conditions or hours required of them by their work in the fields. The third regulation the Environmental Protection Agency put into place is the Worker Protection Standard of 1992. Federal regulation, this was a federal regulation designed to reduce pesticide poisoning by requiring safety training, notification of pesticide applications, using personal protective equipment, restricting entry intervals after application of pesticides, decontaminating supplies, and the provision of emergency medical assistance. It is important to remember that enforcement of these regulations is dependent on the size of the farm and the entity in charge of enforcement in the area. So although we do have three regulations in place to help protect ag workers, they are excluded from several very important labor rights. The right to organize and bargain collectively under the National Labor Relations Act. Ag workers are not entitled to overtime pay under the Fair Labor Standards Act, with an exception of California in 2016. And ag workers are only covered by 7 Occupational Safety and Health Administration OSHA standards. There have been some improvements in some states. As I mentioned, for example, California, Governor Jay Brown introduced a bill in 2016 that expanded when ag workers are entitled to overtime pay. They were the first and only state in the nation to grant overtime pay to ag workers. He also signed a landmark agreement that gave ag workers the right to organize. However, this is not the case in many other states. This means that ag workers have less protection than most other labor groups and are at greater risk for illegal and unfair treatment, injuries and unhealthy conditions, scams, and many other risks. So now that we have an understanding of some of those general demographics and characteristics of the population, their employment and housing conditions, some of the protections and lack of protections, let's talk about what medical conditions are commonly experienced in ag workers, as well as what their barriers to accessing healthcare are. So research indicates that agricultural workers have lower rates of many chronic diseases compared to the general population. But a lack of access to healthcare may mean that they have many undiagnosed health conditions. Some of the common chronic conditions include diabetes, obesity, hypertension, chronic respiratory, and musculoskeletal disorders. The primary challenge for an agricultural worker patient with a chronic disease, especially one who migrates, is continuity of care and self-management. In addition to some of those, excuse me, chronic conditions and illnesses, mental health is also a concern among agricultural workers. Some factors that impact mental health in this population include traveling alone, family separation, lack of family support, lack of adequate childcare, lack of adequate education and nutrition programs for children, and especially now during COVID-19, when we've seen food banks get hit really hard with an increased request for resources, food insecurity is another impact. Agricultural workers may be reluctant to talk about mental health issues due to cultural barriers and stigma. And as seen on the slide, some of the conditions associated with high levels of stress can include anxiety, depression, substance abuse, domestic violence, and PTSD. So next, we're going to talk a little bit about what are some of the individual and also systems level barriers that agricultural workers face related to accessing healthcare. So mobility and long days of work can often threaten health and pose a significant barrier to accessing healthcare, as we've mentioned. Many agricultural workers also have total family incomes below the federal poverty level, as we saw in the demographic data. So limited income can be a barrier. This puts agricultural workers in the predicament of having to choose between paying for healthcare or meeting their essential needs. Many workers do not have health insurance, which forces them to seek medical care only when it's absolutely necessary. So preventative care may not be a priority. Because of the limited benefits that workers receive, sick leave is rarely an option. So workers do not take time off from work to take care of their healthcare needs for fear of losing their jobs. Or if they're paid by a piece rate, as we mentioned before, there may be fear of losing income by taking the time off from work to seek medical care. One of the most commonly reported barriers is language. As we saw in the demographic data, 65% of ag workers cited Spanish as their native language or their preferred language, and therefore their inability to speak English fluently or comfortably can pose a great barrier in healthcare. Many workers also have low levels of literacy, even in Spanish. The culture of the ag worker population can also get in the way of accessing medical care. For example, workers may rely initially on homeopathic remedies that they've been handed down from generation to generation to treat ailments, and therefore they may put off seeking medical care until a condition or issue has become much more serious. Ag workers can be unfamiliar with the US healthcare system and therefore do not seek existing services or have the knowledge to navigate the healthcare system effectively in order to meet their needs. It's a difficult system to navigate even if you were born in the US. Lack of transportation, in rural areas without mass transit can be a barrier. And due to the pandemic and the reduction in staff and staff being sick at health centers, there are minimal transportation services available at this time. Or as mentioned in the chat, it's difficult to even do telehealth or other types of services that we've tried to implement due to some of these barriers. So some of the systems level barriers also can be seen in the individual side of things, but from a systems level, labor policies that include lack of paid sick time and time off is individual and systems. There are community and workplace barriers. There can be limitations to the number of healthcare sites available. Immigration systems and threat of deportation are a barrier. Exclusion from public and private health insurance is a barrier to accessing healthcare for this population. And lack of awareness about the challenges faced by agricultural workers among public health officials and healthcare providers can also be a barrier. Individual racism or xenophobia in communities can create barriers through systemic racism in the workplace, in communities, at healthcare sites, and within labor policies. So how are health services delivered to the ag worker population? So when looking at 330G programs, grantees that receive federal funding to provide services for people in the community and 330G are required to provide services specifically for the migratory and seasonal ag worker population. Although the size and extent of the services can vary by center, the majority do provide comprehensive care within their networks, although it's not uncommon to have health centers offer the basic on-site services and then refer a patient out to a larger clinic within their network for additional services. As a rule, the larger the budget, the more comprehensive the services the health center can offer. But at a minimum, these are the wide range of diagnostic and support services that the federal government requires. So primary care, preventative, emergency, pharmacy, and ancillary services. So in addition to service delivery, there's outreach and enabling services that are critical to serving this population and to reaching migratory and seasonal ag workers. They help increase access to care for this population. As we discussed earlier, ag workers face many challenges in accessing primary healthcare services due to the hours they work, lack of transportation, et cetera, all those things we discussed. So these services are really important for health centers to provide to ensure that ag worker families can have access to the primary healthcare services. So we must work to provide some of these services. So that includes case management, coordination of care, patient and community education, program outreach, eligibility assistance, and transportation, to name a few. So addressing service delivery challenges, it's important to look at our organizational systems to address these service delivery challenges. These challenges can lie within our policies, procedures, and trainings, and strategies to address those can help address service delivery challenges. Organizational service delivery challenges can also be related to capacity, and one thing to consider are wait times. So keeping in mind that demand exceeds capacity. Asking yourself, how long are your wait times? Do you need more capacity? What are your hours of operation? What is your training protocol for staff? Do you have continuing education available for staff around culture and language, customer service, et cetera? And what about continuity of care? Continuity of care is one of the biggest challenges in ensuring quality healthcare for ag workers, mainly because of the mobility of the ag worker population. Even when they return to the same area year after year, continuity of care and managing those conditions can be difficult. Changes in geographic location may occur multiple times a year, which disrupts chronic disease management for conditions like diabetes. What we often see is agricultural workers only seeking care when it's absolutely necessary, or they may begin treatment but cannot continue because it's time to move again. When they seek care in a new community, they may not remember the names of their medications they were prescribed or the dosages, and all of these factors come into play as part of continuity of care. And it's important to consider the ways that we can mitigate poor health outcomes due to this. So two things that we can consider are case management and self-management. So we know proper case management can help prevent the disruption of chronic disease management and can prevent misdiagnoses that may occur when an ag worker moves to a new location, and can even reduce the chance that the patient might over-medicate or mismedicate due to that. And self-management is key in controlling chronic conditions. So it's important to educate our patients in order to help them understand what they need to do to manage their illness and what information or records they may need to take with them when they travel, to help set the stage for the best possible outcomes at any health center that they may access. So we have reviewed what some of the outreach and enabling services are that support service delivery and the importance of continuity of care and how we can empower our health centers and the patient in case management and self-management to ensure the best possible health outcomes for ag workers. So I wanted to turn it over now to my colleague, Lisa, to share some of the tools and resources and opportunities available to support these efforts and increase access to care for ag worker families.
Thanks, Katie. And if you can advance to the next slide, please. Great. So yes, we have lots of great resources available for you all, and I'll share a few here. So the first is our Increased Access to Care for Ag Workers program information. The IAC program and associated training opportunities were launched in collaboration with or in coordination with the Ag Worker Access campaign back in 2015 to assist community and migrant health centers in accurately identifying, reporting, and classifying their migratory and seasonal ag workers in UDS. And since then, the program has really grown to include and become a national virtual network comprised of health centers, health center control networks, and primary care associations, all with the same goal of increasing access to care for ag workers. So you'll see on this slide, our IAC network currently consists of 2 learning collaboratives. We have IAC Core, which really focuses on, ag worker ID, policy, making sure your policies and procedures are, and all those things are in place to properly identify and report your ag worker population. So lots of resources there in our IAC Core. And then IAC Plus focuses on social determinants of health and how we can increase access to care for ag workers by addressing SDOH factors. And these health centers are part of that virtual network. They participate in migrant health action planning and participate in virtual learning sessions through the Learning Collaborative. So a great group to work with. If you're interested, we'll share information with you on that. And next slide, please. And then also our website, it has a great wealth of information available to you all. We have population specific information like population estimates, and that web page has, it's basically a map, and you can search by county in your state to see what those population estimates are. We have some great fact sheets and research documents that you can use. And then also our learning collaboratives. In addition to the IAC Core and IAC Plus that I mentioned, we have several others for health centers to become involved in. We also have some great health education and patient education resources. And those are all, we'll have links to those in the PowerPoint that you receive following this session. And then of course, workforce development training resources as well. And the next slide, please. And then also we have our COVID-19 page, which is another great resource that includes resources for ag workers and organizations that serve ag workers, including health centers, ag employers, and other organizations. And we have the information is in English, Spanish, and some indigenous languages also. So some great page to check out when you have some time, as well as our Call for Health program. Another great resource. It is our resource line. It's available Monday through Friday for ag workers needing assistance finding their local health center. They also help with translation services and other great things that to help the ag worker population navigate through the healthcare system. And that's on our website as well. And then also we are on Facebook, Twitter, Instagram, and YouTube and LinkedIn as well. So we encourage you to follow us on our social media as well to stay up with the latest information. And then we have 2 newsletters that are also great resources. Our NCFH News, and Katie just shared the link to that in the chat, is our monthly newsletter. And that's a great way to keep up with the latest tools and resources available to you, and stay in the loop on everything that's new with NCFH and migratory and seasonal ag workers. And then our Boletín de Sol a Sol is another great resource that is twice a month, and it comes out twice a month, and it is a little more outreach oriented, but a great and another great resource for you guys to access. And next slide. And then, of course, the Farmworker Health Network. NCFH is a part of the Farmworker Health Network, and the FHN works cooperatively with HRSA to provide training and technical assistance to health centers throughout the U.S. And so we have all the FHN members listed here, and we encourage you to visit their websites as well. And next slide. And then before we conclude this part of our training or our webinar, we do want to let you know that we have the Spanish version of this webinar coming up on February 24th. And then we also will have ag worker identification, classification, and reporting in UDS webinars coming up in English and Spanish in May. So if you sign up for that NCFH newsletter, you'll get that information, and we encourage you to be on the lookout for that. So we thank you all for joining us today. This concludes this part of the webinar. For those of you who are joining us live, please stay on because we'll have a live Q&A following this section. And then for those of you watching the recording, this concludes this session.